go through and what Samantha goes through. So Samantha's going to begin because she is a PGY3, so she has already been through the whole residency and she knows a little bit more about what goes on. And so Samantha, take it away.
So, of course, there's a lot of similarities and also differences between internal medicine and family medicine. So that's why we thought it would be perfect to talk about it today. Because when you're applying for the match and going through it, a lot of times you're always stuck between the two and as to what you want to do. So internal medicine is pretty fun. I like it. You get to work with older patients, so no kids, which is the pro about that if you're into that. And then you get to learn about different types of specialties. So typically residency, you go through, obviously your wards are the most heaviest, which is your inpatient medicine. And then you do a bunch of electives that could lead you to your future fellowships. So that includes cardiology, hematology, oncology, rheumatology, endocrinology, and a bunch of other stuff that you could get into after you finish your internal medicine residency. So that's why it's a part of the program. If you want to get into family medicine, Adelynn, take it away.
So with family medicine, usually when I went into the interviews for residency, the number one question that basically in any residency that they ask is why this residency? So my answer for family medicine as to why I chose it is because it's literally a piece of everything in medicine. You don't lose out or don't miss out on anything in medicine. For example, OBGYN. In internal medicine, Samantha doesn't have that in her residency. So as in family medicine, you get to do OBGYN. Like Samantha mentioned, she doesn't work with kids. I end up working from birth until they're 120 years old. So you get a little bit of everything. You get surgery. We do internal medicine type of inpatient work like Samantha does. We work outpatient in clinics, and so, we also do psych. So like I said, it's a little piece of everything and you're always in those areas no matter what.
Right. And it's very nice to look at the differences and compare them, because as you go through residency, you kind of start to see the differences between family medicine and internal medicine more. So internists are more trained in today's world to be more into hospitalist medicine. So we do a lot more wards or inpatient medicine than family medicine counterparts would, because they have to do these outpatient, the OBGYN and the peds and the psych, which we don't have to do. Same thing kind of with the electives. We do a lot more like cardio, endo, nephrology, rheumatology, all of those, because they're a requirement for us for our boards. And because you have the option of doing fellowships in that, where you don't have that option in family medicine. So those are some of the differences to go through. But family medicine does have some cool fellowships, and Adelynn's going to tell you about them a little bit.
Yes. So women's health is something that a lot of family medicine residents are very interested in. You can specialize in just women's health, or like I said, you can do OBGYN. It does depend on what area you reside in. For example, in New York City, it's very hard to be both a family medicine doctor that specializes in gynecology and obstetrics, because it's just so overpopulated with real OBGYN residents. So you kind of are like lower on the pole of how many patients and how big you can get, versus if you're somewhere in the middle of America, it's much easier for you to work there. So we have a fellow actually who in my hospital is doing OB fellowship, and their plan is to work in a other area other than New York, just because of what I just mentioned. Other fellowships are like sports medicine. You can work like with MSK and everything. There's also derm you can specialize. It's a lot. It's just not how Samantha can become a cardiologist, a gastroenterologist, endocrinologist. That is something that we cannot do a fellowship in.
Right. And fun fact, I'm starting my cardiology fellowship this year, so that's going to be interesting. So I will be a resident, I guess, for another 3 years, because resident and fellow is very similar. So me and Adelynn will be riding the wave for another couple of years together.
Yes.
Okay.
And so basically, moving forward, what my practice when I'm done with residency, if I see a patient who needs something to do with cardiology, I will be referring them to Samantha. So that's how it works in family medicine. You can think of family medicine as the middleman. A patient will come to me, they will have some cardiac issue. I will, let's say, send them to Samantha. Samantha will take care of them. And then they come back to me and I just see what Samantha does and continue with their plan of care.
And just so you know, the primary care role can be filled in by internal medicine or by family medicine. So that's a nice thing of how they work well off of each other. Now let's talk a little bit about like our schedules in general. I think they're pretty much similar. All residencies across the board will have their didactics. So we have the morning report, the noon conference. Just some programs will have like a dedicated half day. And other places like my program has every day we have a morning report and a noon conference. How is yours like?
So mine is a little bit different because my hospital is unopposed. We only have family medicine and podiatry residents. So it's kind of a plus because we get to do everything and we're spread out. So in terms of didactics, it happens once a week because of COVID, everything is virtual. So we do spend half of the day doing just either we teach each other or the attendings teach each other, or we do certain questions from New England Journal of Medicine.
Nice. And then speaking of the things that we use, so for internal medicine, we use something called MixApp. That's how we do our questions. And that's what tailors us to our ABIM, which is our internal medicine boards that you take right after you graduate. So I would be taking it in August of this year.
Yeah. So we can use New England Journal of Medicine. I'm still using UWorld because I still have to take step 3. So that's how I like to, that's the apps that I like to use questions on.
Now, the other things that are very important that we all, I think, use in every residency program, and no matter what specialty you're in, is something known as Uptodate. So Uptodate is basically our algorithms, our pathophysiology, our pharmacology, our everything about the do's and the don'ts of any illness that the patient comes in with. It's a nice tool to have. Obviously, there's a lot of information in it, but you learn as you go through residency, you learn to see what to focus on. So if you need to figure out how to treat diabetes really quick on the spot, you go there, you look at their algorithm, you'll read about the different drugs, and it helps guide you with your therapy. And it's really been the holy grail for anyone in any specialty across residency.
Yes, I also use Uptodate. I love it. Also, AAFP is another thing for family physicians. Every half of the month, there's a new article with like 3 top articles where it's just giving you up to date on family physician practices and how we should screen patients, any new updates. So that's another free app that you can get as well.
Yep, even I use AAFP, especially when I'm in clinic. So I wanted to talk about clinic. My clinic is scheduled, it's a 4+1 schedule. So we do 4 weeks of inpatient or electives, and then the 5th week you go to clinic, and that's my clinic week. Some places have like a half day a week where they do clinic, like I'll be doing that in fellowship. And the clinic structure is very nice. I think it's very important. But I also think that depending on what you're doing, the clinic may not be structured perfect for our residents to be comfortable doing outpatient medicine, as I feel like maybe family medicine people are a lot more comfortable in doing outpatient medicine. So can you tell me a little bit about the difference between your clinic and mine?
So I actually really love outpatient clinic. How it works with us is that my rotations are basically split up into 2 weeks each. So for example, right now I was in the VA hospital doing surgery outpatient clinic. However, I was still returning back to my campus and doing my own clinic. So how that works is you're there every day. When you're an intern, which I am, you basically start off with 4 patients in the morning, 4 patients in the afternoon. Now, because we are more advanced, I see anywhere from 6 to 8 in the morning and afternoon. And so the most important thing about my clinic is that you have to set an agenda as to why those patients are there, because as you know, somebody can come in and come with a laundry list of what's going on, and we would love to help, but it's just so time consuming that we have to focus on what's mainly important, and that's what we're taught and helped to do that. So clinic, we basically have a continuity. So I get a new patient And then I schedule to see them with myself. If I'm unavailable, I assign it to a co-resident, but those continue to be my continuity clinics, and it's technically like as if it's my patient.
Yeah, our clinic is very similar to that. So as you progress, you'll be able to see more and more patients. And obviously you get more comfortable seeing more patients in a limited amount of time and learning to focus. I think that's the big thing of internal medicine and family medicine, and really your intern year is learning that not everything is important and learning to focus on the most important thing now, and then everything else later with subsequent visits.
Yeah. And in terms of focus, I just want to say that if you're here and you're going into residency, if you are in residency, I think that the main key is that you're there to learn and progress every single day. If you don't know something, that doesn't make you any different than the other person that's in the room with you. You are there to learn, and we all can sometimes not know something, and that's okay to not know something.
That's exactly true. And that's going to be for the rest of your life. There's always something you won't know. So you look it up, you learn it, and you'll never forget it. Especially when you're like in clinical medicine, it becomes repetitive. So most of the things become second nature. As you keep doing things over and over, it's very hard to not learn it. You're just going to even learn it passively. Okay, so I wanted to get into a little bit about, now that we got outpatient out the way, let's talk about inpatient medicine, maybe our schedules and nights as well, because they're kind of similar. So it's going to vary from residency program to residency program. So Adelynn will also chime in about her hours. So my call schedule, for example, when we're on wards, is we're on call every day, as opposed to other programs that they have different call schedules, like post call or whatever. So our calls are basically, some days they're till 1 p.m. that we take admissions, till 4 p.m. that we take admissions, and till 6:15 until we sign out to night team. And then at night, you're obviously always on call from 7 p.m. until, ours is I think 5:45 in the morning the next day. So you could have an hour and a half to finish your notes and stuff. And typically the schedule is obviously a 12-hour schedule. If you get out early, in some programs, you could get out early depending on when you stop taking admissions and if you finish your work on time. And you come in at 6:45, you chart review your patients, you go upstairs, you see all of them. And then after that, you end up doing your rounds with your attending, finish all your orders, your discharges and all of that. And then the rest of the day, you're kind of just tying up loose ends. Is yours similar to that?
Yeah, it kind of is. So basically, like I said, my hospital is unopposed. So I am considered the internal medicine resident because we do take care of the med surg floor, the ICU, the telemetry floor. What happens in terms of hours? It starts from 6:30. You should be there to look at your patients, to get sign out from the night resident. And then what happens is we round in the morning. Because of COVID, we don't go room to room, how some other residencies, for example, when I was in clinicals, we would walk room to room and round. But we sit down with the attendings, we go over the list, and then we go and round on our patients either with the attending or by ourselves, depending on if we feel comfortable going alone or if the attending wants to go with you.
Right.
So after that, we write the notes, we respond to any codes if they occur, and we take in admissions. Admissions for us technically end at 5 because the night residence comes in at 5:30. But obviously, when you're an intern, you never leave at 5:30. You could leave at 6, 7, because you're still there writing notes, and an admission can come in any time. And that's where you will learn from admissions, because when you're a second year in my family medicine program, you do nights by yourself and you are the one that's getting all the admissions, which is kind of nice because you're there just doing admissions. You're not doing any progress notes on any other patients.
Yeah, that's definitely the pro of nights, is doing just the admits. You get to learn a lot because you have a lot more time to read up on your patients, as opposed to dealing with case management and social work and all these other things to set your patients up. You guys will get there, trust me.
Yes,
it's not fun.
understand.
But it's a good thing to learn. You know, it's going to be very important in your future of how to manage things, and you learn about the insurance issues and all that. Okay, and then ICU, which is the bane of my existence. ICU is like a 12-hour shift also. It's similar to my medicine and my nights, except that you are taking admissions up until like 7 o'clock, unless the resident who comes in at 7 is like, oh, I'll take over from here. So, and you run rapids at that time and also do codes. So that's our ICU people are big on the rapids and codes, which is nice because when you're in medicine, then you are present at the code, but you're not necessarily running it because your ICU team is doing that.
Yeah, and so for me, I personally haven't had my rotation in ICU because that's a second year like subject. So what happens is when I said I do have ICU, we still go over the patients that are under our service. I don't write their notes unless they are my patient who were transferred from, let's say, telemetry or med surg for any reason, because we do have an ICU resident already there. In terms of what they do, a little bit that from what I know is that they work the same 7 to 7 and they continue to write notes depending on what goes on.
Right, and ICU is also the place where you could get all your procedures done. So you'll be doing central lines, thoracentesis, which is taking out pleural effusions, paracentesis, which is taking out fluid from the abdomen, and ABGs, A-lines, and all of that. So now that we went over like those main cores, let's talk about some of the electives. So I'm just going to go through the list of the electives that internal medicine has. It's a pretty long list, but you could subspecialize from internal medicine in any of these. So it could be a 2-year fellowship after that, 3-year, 1 year, depending on what you get into. And some of them can actually be broken up. So for example, pulmonary and critical care medicine is a 3-year fellowship, but you could do them separately. So it'd be 2 years of pulmonary and 2 years of critical care. There's also nephrology, medicine, pediatrics, ambulatory care, which is pretty rare for IM people to go into. That would be more so someone that from family medicine would do that. Infectious disease is another one, hospitalist medicine, which is you go straight through, or you could do a fellowship in that as well to get more specialized in it. Hospice and palliative care is another one, hematology, oncology, geriatrics, genetics, general medicine, gastroenterology, endocrinology, cardiology, and allergy immunology. The only thing I want to mention is that in terms of derm, there's no actually like dermatology fellowship. There are unaccredited fellowships, which is something that you'll learn once you're in residency, that there's a difference between accredited and unaccredited, but you could do further into like derm, like doing aesthetics and getting certified, but you could do that with anything. It's just that you're not necessarily doing a full fellowship program for that. And you could do the same thing in family medicine with that.
Yeah, and also what I forgot to mention with the fellowship in family medicine, unlike it's being 3 or 4 years, it's actually 1 year. But you aren't accredited in terms of, let's say if I do a fellowship in OB, I am not going to be an OBGYN. I will be a family medicine doctor who is able to perform C-sections and deliver vaginally because I did my fellowship.
Yeah, perfect. And then there were some other fellowships that you guys can do, right? Sports medicine is one of them. And
yes, so you can become a hospitalist. For example, there's one resident who was in my program and now she's a hospitalist in my hospital. So there's a lot that you can do with that.
And sleep medicine is a fun one that you can do from both family and internal medicine. So there is some overlap, except for like really the big ones, which I mentioned before. And then otherwise our electives are pretty similar. And then you get to do peds and OBGYN, and the schedule, I don't know how your schedule is because I never have to do peds and OBGYN. Kudos to me.
So I actually work in a different hospital for pediatrics, and I work as if I am a pediatrics resident. So I work under that hospital's hours. I don't know how it works with other family medicine programs, but when you're there, it's very refreshing because even though you are a family medicine resident, you are with the other pediatric residents. So you're technically considered a pediatric resident at that point. And then outpatient, you're just with a pediatrician. So you just watch what they do so that when you do have your own practice, if you want to work with kids, you know exactly how and what you should manage them. And then in terms of OB in my hospital, there's no OBGYN residents. So I'm considered the OBGYN resident. And so I work with the fellow and the attendings, and I do C-sections and vaginal deliveries. And it's very good for me, I would say, because I get everything hands-on and I don't have to compete with any other resident who wants to do C-sections or vaginal deliveries.
Awesome. And then the last thing I guess we can talk about is research and all these other fun extracurricular things that you can do in your hospital, I think we would both recommend to get involved. We both got involved very early in various things. So like wellness, we're involved in wellness, and we're doing research. Obviously, if you want to do a fellowship, research is super important. If you want to go into academics, research is super important. But that will differ from residency to residency program as to what access you have. So if there's no program, like a wellness committee, for example, if that doesn't exist in your program, go ahead and start it. Like, it doesn't have to be amazing, and it doesn't have to be all put together from the jump. You know, we both have started that and took that initiative, and now these things are self-functioning. So when we leave, this will continue to work. And same thing with the research. In my program, we do have like a dedicated like statistician, but you still have to do the bulk of the work and push them to help you get your research through, especially where I have like 230 residents, because we have a bunch of residency programs and fellowships. And that's why it becomes very important to become self-sufficient. So whatever you were doing in med school, you continue to do in residency.
Yeah, and with my research, you're supposed to do a research on anything that you want, and then as a whole with the class. So for example, the upperclassmen, what they are doing is that they are trying to see how many people are actually getting screened for Hep C. And so they did this whole qualitative thing where they're checking our EMRs to see how many patients we actually screen. And I don't know the whole details because I'm not involved, but I know that they're doing it all as a class.
Speaking of EMRs, there are different
yes.
EMRs at everywhere. So I use Meditech at my hospital just because I think they own Meditech. A lot of people don't like it, but once you know how to use it, it's actually very easy to use. There's also Epic at some of our clinics. We use that, and eClinicalWorks. Do you use the same?
Yeah, so I use eClinicalWorks, Meditech. I also use the VA system that they have in their hospital. So yeah.
Don't be scared. You'll learn it. It's just a part of the process. Maybe one day we'll have like a EHR that was like global for everybody, because it would be so much easier to get access to patient information and knowing what happens to them, because a lot of patients can't give you the information that you need. Okay, so I think I'm done from our standpoint. You think we're good?
Yeah, I feel like we can open it up to questions because I know that a lot of you have many questions to ask us.
Yeah, and we'll get into more detail.
Yeah.
Thank you guys so much. This was super helpful. A lot of us weren't really sure of the differences between like family medicine and internal medicine. So thank you so much for really clearing that up for us.
Awesome.
I guess before we get into some of the questions that people were asking throughout the presentation, yesterday we had a lot of questions asking about like match for residency. So how exactly that works, and like when you decide what residency you want to pursue, if you can like pick more than one and things like that.
So I want to start off by saying how I know personally when I was in medical school, everyone was so into, oh my God, you have to get a certain step score to get into a certain residency. For anyone listening, I want you to forget those words and don't ever listen to other people and what they say, because that is going to mess you up and make you very nervous and make you lose hope and just not make you work hard enough to what you want. Just focus on yourself, stop listening to what everyone has to say, and just study hard. So that's my piece about that. In terms of applying, so now step 2 CS is no longer with us. So in terms of CK, it's still a score. Step 1 is going to be pass or fail. In terms of match, Samantha, you could chime in if you want to.
Yeah, so we don't know for sure how that's going to affect people. Theoretically, the fact that it's pass or fail for step 1, they'll probably focus on step 2 as the guarding point of if you qualify for that specialty. So yes, like Adelynn was saying, obviously don't let anyone tell you you can't do something, but you also have to be realistic about when and where you can apply. So we're very big on, if we want something, we're going to get it no matter what. We've always been big on that. That's our whole brand in general. But so for example, if you want to apply for surgery, there is a certain cutoff that you need to look at. So now that might change, because now that step one is pass or fail, technically all of us can apply for surgery, no matter how high your score is or how low your score is. So, but there are other things you can do to boost up your CV, right? You want to get your resume got to be on point. You want to show that you're volunteering, that you're doing a bunch of research. You want to show to people basically when you're applying, I'm more than just what my scores are. And I think that makes all the difference for when you apply. And that's also going to affect this match, I think, as well. So we're not sure if the scoring system is going to be beneficial for IMG, but it should be for international medical graduates, because theoretically, you're going to be able to compete with the US medical graduates based on like the score. I don't know if that helps. I hope that's.
Yeah, that's super helpful. There's a lot of people just kind of wondering like what's going to happen now that step one is pass fail and the CS is done. So thank you for that.
Should be.
Yeah, hopefully. So the next question that a lot of people were asking was just like, how do you make time for personal time? Like in residency, it's some pretty grueling, can be grueling at times. So like what's your work-life balance like? How do you help yourself like prevent burnout and stress?
So I think that depends on your schedule. So every intern, typically your intern year is always going to be your hardest. And every intern year may be harder or easier than another place. And that's just how it goes. You just got to find time for yourself. And also when you rank programs, look at how the residents are. If the other residents look like they hate their lives, then you're probably also going to be burnt out there. If they look like they have like the balance, like this is something that's very important to ask. So you have these meet and greets that you can go to and ask the other residents about how they're doing. Most of them, you can tell if they're lying or not, but most of them will tell you the truth because it makes no difference to them. They want you to go to the best place that you can get to. So I think looking at that is very important in making your decision about work-life balance. And then in terms of work-life balance, like I'm in California, so I have beautiful weather. Everything's nice, even though I'm originally from New York. So my work-life balance is awesome. My PD is huge on wellness. Every month, like pre-COVID, we would do yoga sessions or pizza parties. So they were very big on making sure that you have, like, you don't burn out. And if you do, we have mental health resources for that. And we're super big on that as well. Adelynn, how about you?
Yeah, I think that my program also, we do have mental health. We can always reach out if we need to speak to someone or we are feeling burnt out. I personally love my schedule, even though sometimes it can be overwhelming because I travel from New York to New Jersey every day. So the whole traffic thing is what kind of burns me out. In terms of what to do on your days off, that is your time you can relax in bed. Who cares? This is your time to just sleep, watch Netflix. The pandemic helps a lot because you can't really go anywhere or do anything, which is kind of like, yes, a hit or miss, because if it wasn't a pandemic, you would be out doing stuff. But I think you should focus on what you enjoy doing. For example, if you love to read, read a book. If you love to listen to a podcast, listen to a podcast. Work out. Find ways, like take little breaks. If you eat, make sure you eat. I don't know how people every day in residency can go their whole day without eating. I noticed that once I can't focus on the computer, I need to go take a 5-10 minute break, eat something, and then continue. I just don't know how people don't eat in residency. So make sure you do that.
Sure.
And yeah.
Yep.
Perfect. Thank you so much for that. That's good to know that there is hope, because we heard horror stories about residency and just never having time for anything. So it's good that, you know, you do make time. We also, since you guys both mentioned it, how has COVID impacted your training and what like the actual nitty-gritty of your education has been like?
So I actually started after the whole pandemic began. I started last year. In terms of what I expected, our hospital was very good at giving us PPE, at letting us not have to necessarily go and see the patient, to expose less people. And I was actually I started in OB, so I wasn't in the inpatient team taking care of all the codes and everything when it was very crazy. So I don't really have a personal story, but Samantha can share more about it, because in my hospital, it wasn't as bad as in California.
Yeah, so in terms of COVID, so I think for me, I kind of lucked out in the fact that it started hitting towards like the end of my second year, like the second half of my second year. So I got the bulk of my intern year experience of the things you need to learn, like diabetes, heart failure exacerbation, heart attacks, and all these other things that are your bread and butter. I think for a lot of people who started their intern year like Adelynn did, it kind of did a disservice in terms of their education because they were just seeing COVID. If you were on inpatient medicine, all you saw was COVID patients, and it's literally repetitive, the same thing over and over. You're kind of not learning anything else aside from what you're doing with questions and all of that. So I think that was definitely a downfall, but these people will be able to catch up next year, like as second years or as third years. So I think it'll end up working out anyway. It's just a little bit of how it started. The other thing is I want to mention about COVID is initially, like she was mentioning her PPE situation, for us, we had to implement all of that. We as residents collectively went to our program director and was like, listen, we're not seeing COVID patients if you guys don't have the proper gowns, the proper PPE and all of that. I think residents forget that they have a lot of power. And there's a lot of residents in a program, especially like a program like mine, where our voice is like so big that we could actually make an impact on our health. So I think in the beginning, we were all very scared about seeing COVID patients, obviously some more than others. And then with time, it kind of became normal because this is the new normal. We're gonna have to be seeing these patients, but now we learn how to protect ourselves, plus with the vaccine, to be comfortable seeing these patients. It was the same thing for residents when in the 80s, when the HIV pandemic happened. It was the same thing when TB happened. So with time, you learn the new normal. I mean, it's been kind of crazy, but also kind of cool because COVID is new and you got to learn how to manage these different patients and balance them out and learn new medications. Like you feel like you're at the forefront of something new and something experimental, which is kind of cool too.
I like that.
Yeah, that was awesome. So thank you for that. Appreciate your different perspectives and experiences during the pandemic because, you know, hot topic.
Yeah.
Kind of stepping back really quick. You know, when you guys mentioned beefing up your CVs in medical school and even in undergrad, I guess, what avenues or ways would you recommend doing that?
So if you are in a medical school that has clubs, or let's say there's a club that you would like to start, do it. Make sure that you show that you are doing something in medical school. I know now I saw a lot of people from my medical school, they asked to volunteer, help out during COVID. So I think that's a very big plus right now to be doing for sure. Samantha mentioned how we started research earlier. In medical school, we already applied to conferences. We got published in medical school. It's very easy to do. I don't know about now, like Samantha said, all the heart failure and all of these things that you can potentially write a case report on. Now it's mostly COVID patients. So it probably is a little bit harder. And then what else is there?
I think maybe I'm not supposed to say this, but fake it till you make it. And I don't mean like fake it as in like make stuff up on your CV. But let's say if you're a member in ACP or you're a member in a group that you did in med school that you didn't personally start, but you're a member of it, put it on your CV. Like that makes all the difference. Same thing with research reports. You are going to initiate a lot of research reports, but they're not all going to get pushed through and they're not all going to get published. So you can list them that you submitted them, even if they're not published. They'll make your CV look bigger. And then if you get asked about it, you can explain, like, for example, right now, some of my stuff didn't get pushed through because of COVID. And I just explained it and I discussed my research because I did work on putting all that information together, even though it's not published yet, you know, so you kind of like work the system to your favor whenever you need to. So I think that's important for the CV. And then also oral presentations. A lot of the time in residency, we have to do morning report presentations, like case presentations or journal clubs. That should be included in your CV. Don't let anything that you have done go unnoticed on your CV, especially if you're applying for fellowships.
Great, thank you so much for that advice. That's super helpful. Yeah, just kind of put everything. That's what we're learning as well.
Yeah.
So another question a lot of people had was, for you guys talked about procedures in your specialties, and so people are asking like, what procedures do you each like do individually, and what like can't you do in your specialty?
So in my hospital, for example, a central line, I can potentially ask my attending to try to do it for him to show me, to help me. But realistically, if I'm going to be working outpatient, how many central lines am I going to be doing? As a doctor, I think that you should know how to do it. So if there's an opportunity for you to learn it, I say do it. In terms of procedure in the clinic, for example, the other day I did steroid injections into someone's scalp for hair loss. I've done a punch biopsy. I've also worked with like a ganglion cyst. Like you could do derm stuff in my clinic. And then when I did my MSK elective, I was injecting steroids into hips, into knees, hands. So you can do a lot of stuff in family medicine.
So yeah, same thing for us. You could pretty much do any procedures. There are certain requirements that every residency program has. So like, let's say my program, we have to do at least 3 pap smears. Obviously, family medicine is going to do more than that, but we don't have to. Yeah. So, but we just have to do 3 and then you're done with it. You never have to do a pap smear again if you don't want to. And then the other thing is we have to do 1 central line. Internal medicine people are pretty good at central lines. They should be, because you do a lot of ICU. You do at least a month every year. So you end up doing 3 months of ICU plus ED. When you do your ED shift, you also do a lot of these procedures. That kind of goes along with thoracentesis, paracentesis, but none of those are required to graduate except for the central line. ABGs, you need to do 3 to graduate, and I think 1 peripheral IV. And it's funny because a lot of us don't know how to do peripheral IVs because nursing staff usually does them at most of the programs. There's very, very few where you have to do your own lab draws and troponin draws. I feel like that's maybe only in New York, but that's still even a thing. And then intubations, obviously you can do all types of procedures, INDs, all of that. The only thing is you can't do surgery is the only thing. And obviously it depends on your attending, how comfortable he is letting you do all of these procedures, but you should be able to do all of them. And then there are programs that, like at our program, for example, if you don't want to do procedures, no one's going to force you. And then there are people who are super gung-ho about them and do a bunch of them. So kind of just depends where you end up. But the minimum requirement is very little type of procedures. So like I said, ABG, central line, peripheral IV, and pap smears. I think that's it. Oh, and a code. You have to learn how to run a code.
Yeah. Great. Thank you so much. I think we've kind of like, if you're not doing a surgical specialty, like you never do procedures. I think that's the mentality that a lot of us have. So thank you for clearing that up. There was a really interesting question earlier when you guys were talking about like finishing notes. People are wondering like what exactly that entails and like how much paperwork, or I guess like EMR stuff you do and like what that looks like.
So format.
So in terms of finishing notes, a progress note and an admission note is completely different. Admission note, you have to get the bulk of why they're here, their symptoms, like their whole story. Then you have to go into the whole, it's like a SOAP note. You go into their past medical history, their medications, allergies, all of that. And then why they are here and how we're going to treat them for what they are here for. Versus a progress note is exactly, an attending actually once said it to me because he was laughing at all of us that we don't understand what a progress note is. He goes, Google what a progress note is. It's literally a progress of what has been going on. You don't have to go over why they came in or anything. It's what happened overnight. You read the nurse's note, you speak to the nurses, you see if anything happened from the night flow person, and you just write the progress. So it's a little bit better than an admissions note.
Yeah, for sure. I'll second that too. I also think different institutions have different rules just because of like billing purposes and whatever. So in mine, obviously, like she was saying, the SOAP note. So you would initially when the patient comes in, again, you would do the H&P. Okay, fine. And then the assessment and plan is really your bread and butter. That's like the most important part. So you say 32-year-old female, past medical history of whatever, came in for abdominal pain. And then you put in like there's like different ways you put it in, but assessment of basically what they're in for, like abdominal pain, and then the causes of the abdominal pain, then history of diabetes, history of hypertension, whatever. And then your plan as to what you do for each. And there are different like schools of thought, or if you put all of it at the bottom, if you put it after each assessment, you put the plan. And then obviously at the end, you always put fluids, electrolyte, nutrition, DVT, and GI prophylaxis, and their code status. So that's typically how the assessment and plan is done. And then you learn little tricks, like let's say review of systems. In my hospital, for example, you could sit there and click every single review of systems for like a year. But I found the neat trick that it still is covered by billing. So I just put 14-point review of systems, negative except for blah, blah, blah. And I don't have to sit there and click. So you just learn how your system is, ask your attendings, see what your attendings prefer. Some attendings want long notes, some attendings want super short notes. Same thing for discharge summaries, like someone else is going to be reading it. So you want to make sure that whatever you're discharging the patient on, the next doctor who's reading it, it's going to make sense to them as if you are that doctor reading it.
Yes. And then another thing, I'm sorry, that I want to say about notes, what Samantha and I like to do, let's say we're going to clinic, we already know what patients we're going to see versus the hospital. You don't know what you're going to get. So what we like to do is pre-chart. We'll look at the patient, see what they're coming in for, kind of already write half of their notes and click a few things so it saves us time. You're going to learn this as you go on. When I started, I was not doing, like, I didn't know what to do, but don't worry, you're going to know everything.
That's great. Thank you. Because it did sound like a lot, honestly. But that's good to know that we'll figure it out. So we had a lot of people asking about, for both of you, was like, how did you know like medicine was for you, or like which specialty you wanted to go into? And we did have someone specifically ask Dr. Gelman, like how you decided you want to do a cardiology fellowship.
Okay, so in terms of why medicine, so I was always between medicine and surgery. I loved my surgery rotation. I did it out in Miami, and like they let me do everything. So I think that's why I fell in love with like the surgical procedures. But then I started seeing how surgery residents weren't particularly happy, at least from my experience. And then in the long term, it's a very gruesome lifestyle for the amount of money you get paid. And I know it's not supposed to be a financial thing, but at the end of the day, when you're working your butt off so many hours, there has to be some sort of reward aside from being burnt out from your job. And I think a lot of the times that I've noticed that a lot of people weren't happy unless they went into plastics or something like that. But for a general surgery, I didn't like see as an IMG going into gen surg and then maybe not getting into plastics, like that I would have fell apart. So I started looking at IM, and IM having all these other fellowship options gave me the opportunity to basically do surgery, but least invasive. So in cardiology, you get to do stents, you get to do TAVRs, which is like aortic valve replacements non-surgically, mitral clips non-surgically, basically everything that you do. And then the last resort will be surgery, which today cabbages aren't done like that anymore because it's such a high mortality rate. So the cardiologist is doing most of it. So I think that's what got me interested in doing medicine, and then further got me interested into doing cardiology because I get to, yeah, my lifestyle is not going to be amazing, but I'm going to be financially supported. And I'm also getting to do something that's super meaningful, and I'm changing people's lives. And I think that is why I chose cards.
My answer is basically similar to Samantha's. Obviously, I can be a cardiologist, but in terms of, like I said earlier, why I chose family is because I get bored very easily, so I need change. And the fact that I can see kids and then see someone who's 90 years old, I really enjoy that. And then I can see a pregnant lady. It's just a mixture of everything. So something is always new and you don't know what to expect. And I love the outpatient setting. I would love to have like a private practice. So that is why I loved choosing family medicine.
Perfect. Thank you so much. That was really cool to hear. You kind of did just mention the answer to the question that was next, but in general, like, what are y'all's long-term goals post-residency and fellowship? Do you see yourself in the academic side, the private practice side, somewhere in between, working together, hopefully?
So definitely working together.
Yeah, we definitely want to probably do something on a bigger scale. Right now, there's like a huge thing with group practices. So that's something that we want to do. Have like a bunch of different clinics, everyone work next to each other in close proximity. And it helps you because you're working with people you know and you trust. And it helps your patients because they get to have like all their physicians in one place and you kind of know what's going on with everybody. So let's say they'll go to Adelynn for their primary care needs, and then they'll go to, let's say, me if they need cardiology, someone else for their eyes, and someone else for urology or whatever. So we kind of want to build that like multi-specialty practice. Also, I think me and her are super big on women's health and preventative care. So even in cardiology, I'll probably be doing like a little bit of primary care, preventative medicine, women's health, and I'm sure she's going to be doing the same thing from family medicine. And we love aesthetics because we want to stay young forever. So there's a lot of things. There's a lot of options in medicine. That's what's so nice about it. You could do a little bit of everything, and we'll see where it takes us. Oh, you could talk about podcasts.
Oh, well, yes. Also, that's actually something that I wanted to mention. So when you are putting stuff on your CV, put something unique about yourself and have something to back it up. For example, if you like cooking, don't specifically start. Social media is so big right now, and start something with social media. If you love to cook, show like what's healthy in terms of whatever you love to cook, show how it can help you, how it could work with wellness. So that's something that me and Samantha actually started when I was applying for residency. We started a podcast on beauty, health, and wellness. And we actually speak about medical stuff to spread awareness from two physicians' perspectives. So that is something that when I was going on my interviews, everyone was like, what's a podcast? And that just opened up the door for me to sit there and explain to them what a podcast is. And it's something that I could honestly say made me stand out, because I don't think a lot of medical students who are applying for residency, especially back then, knew what a podcast was. So something that makes you stand out, I think, is very good. Start a new blog. I don't know about TikTok, but like start something.
Nonprofit.
Yeah, start a nonprofit organization. We know someone who started like a COVID-19 blog to spread awareness about it. So whatever you enjoy doing, I suggest make yourself stand out.
Yeah.
Great. Thank you guys so much for this advice. Super beneficial. We appreciate it so much. There was another question asking about how like the didactics portion of your residency prepares you for your boards. Like, do they, are you preparing for your boards like part of your residency, or is that something that you kind of do on your own, like studying on your own and stuff?
I think it's a mixture of both. Like I said, we have an hour sometimes dedicated to someone just going over New England Journal of Medicine questions. We do it together as a group. It's actually kind of fun to see how other people think and then to fight over what's the right and wrong answer. And then when I have to present, I basically am making up my own presentation. I have to do my own research. So I technically am studying because I have to know what I'm speaking about. And then, of course, residency is very hard in terms of finding a time to study, because in reality, when you come home after a long day, the last thing you want to do is sit there and do questions. So you have to find a time, maybe like if not every day, every Monday, Wednesday, Friday, do questions, or on the weekends, if you are off, do questions. Find what works for you so you don't overwhelm yourself and don't burn out.
Yeah, I'm going to second that. I think it's definitely both. Our didactics are scheduled where sometimes we do mix-up questions, so that's obviously tailored to your boards. But yeah, you're going to need to find time to do it on your own. Every person is different. Just like studying in med school, it's going to be the same thing in residency. Some people need to start right away, and some people can cram last minute and pass with flying colors. It just depends on the person that you are. But you do have a board review course that you do. We're doing Awesome Review, and our program pays for it. It's like 2 weekends. So I'm studying a little bit before, and then I'm going to go do the board review course, and hopefully after that, I'm ready for boards. So they definitely, your program will support you with that. But of course, you're going to need to do your own learning. And you do a lot of the learning on the job too. So yeah, it's kind of, it's not like when you're studying for step one, you've had no clinical experience and you just have to rely on the book. You really get life experience at this point.
Exactly.
And it's easier. It's easier.
Like Samantha said, with Uptodate, when I have a patient in the clinic and I want to already tell my attending what the plan is, because it's that time of the year in your intern year where you actually should be knowing what you want to do with the patient. In the beginning, you get away with it because they help you because you don't know. I quickly go on Uptodate and I read up about it really quick so that I know how to manage the patient and what my plan is. And they, of course, help you out. They explain it to you. They'll tell you their opinion. So you do learn throughout the day, no matter what, even if you're not specifically sitting there and doing a question.
Awesome. Thank you so much for answering that question for us. So a lot of people were wondering about just imposter syndrome, like in general. If you guys experience it, especially like as women in medicine, have you ever experienced, like had any bad experiences, and just how you like overcome any negative experiences?
I wouldn't say I've had imposter syndrome per se. I would say that maybe I've had those experiences where I, like during COVID, where I was like down and I was kind of like, I can't see these patients, like I can't come close to them, I can't have that same relationship with them. Half of the time you're scared of them and they're scared of you for giving something to them, or vice versa. So I think that was like the hardest part for me in medicine, because I'm typically a very happy person, especially with my patients. I love to mingle with them, I'll sit them and talk with them for hours. And I think during COVID, you kind of lost that relationship with your patients. But how you work through it is that you realize that there is light at the end of the tunnel. Like now I am in those rooms with these patients, I'm vaccinated, I feel more comfortable. And you can find ways around that. Like, for example, some people put pictures of their actual face on their scrubs, and then that way their patient sees what they actually look like behind the mask. And you find ways to develop relationships. Like, humans are so like resilient, you end up adapting to whatever environment that you're put in. So I think even if you go through burnout or imposter syndrome or any of those things, you just got to think about, okay, how do I get through this? And what's like, there is the light at the end of the tunnel, and I just need to keep working through it, keep pushing at it, and never forgetting who I am and why I got into this.
Well, I'm sorry, what was the question about the woman at the end?
It was just like imposter syndrome, especially as women in medicine, like if you've had any negative experiences and how you kind of just like overcome any negative experiences.
So actually a fun fact about my residency is that my whole intern year is filled with females. There's not one male, so power to us. But I feel like I haven't had any negative feedbacks from my attendings, from my patients. I think the environment is a very good one where I am.
Perfect. Love to hear that. We love the women power here as the four of us are talking. So there was, I guess, a question that kind of leads a little bit more towards our wrap up. But if there is one piece of advice you could give yourself as you were undergrad students, you know, before you started the official part of the med school residency journey, and if you were a student now, would there be any difference in your advice that you'd give, and what would it be?
So I actually said it earlier. The advice that I would give myself is not to listen to anyone. Don't let anyone tell you that you can't do something, you can't be someone. I have a personal story where when I was applying for medical school, I had to get like an evaluation or something from some of my teachers, and one of my organic chemistry teacher literally laughed at me. He was a male, he laughed at me that I will not, like, that I want to get into medical school. He thought it was a joke, and look at me now. So I just want everyone out there, even if you're a male, if you're a female, don't listen to anyone. If you want something, you can do it. Just put in the hard work and you will get there one day. It won't be in a couple of hours. It might not be next week, but it will happen. So that's something that I would tell myself and would love for all of you guys to listen to.
I second that. I had a similar experience in high school, actually, where when you get your awards at the end of the year, they give you like excellence or whatever. I had effort in physical education, which I love to tell that, because I was the class clown. I didn't really go to class and whatever, but I always knew that I was going to be a doctor. I didn't let anyone tell me otherwise. So you kind of do what you have to do. So definitely what Adelynn was saying, also be yourself, be authentic to you. I know people keep saying that even though they're not. But the reality of it is it's very important to be honest just with yourself. No matter what you portray to everyone around you, I think that will be what gets you the furthest in life. And finally, teamwork. I think working with other people is super, super crucial. You are going to see people who aren't going to return the favor or whatever, and fine, F them, like you don't have to deal with that. But teamwork will help you not only get where you need to be, it'll help you boost your CV if you're putting each other on different projects, and it'll help you build a network of people that you want to work with in the future. I think those are the main things. And don't worry, like everyone goes through things differently. Some people have a really hard time in their intern years. Some people get the intern year just like that. But eventually you all learn the same information. You all get to the same point. And with time, you'll learn to be efficient and learn everything. I think that's pretty much it.
Yeah, and also another thing, when you're studying for the STEP exams, do not read those forums. Do not read them. People are lying there. They're telling you, they're just making up lies just to get into your mind. Don't read them.
Don't let people freak you out, basically. Yeah, that's it.
Perfect. That's good to know all of that. And thank you so much, everyone. If you guys want to open up the chat now, you can. There's so many people earlier and throughout the whole session just saying that this was so smooth and seamless, and they loved hearing the differences in both of your point of views because they're both similar but different. So it was really awesome to hear all of the words of wisdom and the advice.
That's awesome.
Were amazing. So thank you so much.
This is so much fun.
Like, inspired, gave me like a boost of energy. So thank you for that as I get to study now. So
awesome. We need it too sometimes. So everyone's got to support each other.
We're always willing to come again and share any specifics or give you an update when Samantha starts cardiology and I'll be a PGY too. I'm sure there's going to be so much more that we have learned and that we could share. So thank you guys for listening. Also, we really appreciate that you took your time out of your day to come here.
Yeah, it's a Sunday. This is
Sunday fun day.
now people are leaving, but there was like over 200. So we had a good turnout for today, and we went ahead and put your I'm doing right now. We put your Instagram in the chat. So for anyone who wants to go check them out, they have really awesome advice and just like tips. So thank you guys.
Message us, questions, concerns. We're here for you guys, and we'll do the same. We'll ask you guys questions if we have any.
Yeah, we'll definitely keep in touch. We would love to have you guys back on in the future. I think everyone loved these little like informal kind of like tidbit sessions. So thank you.
Thank you.
We can't wait to see what's going on. And
yeah, we're excited.
Fellowship in PGY 2 years. So.
Likewise in your lives.
We're invested in the journey now. So but we will definitely keep in touch and hope you guys have a great rest of your day and a good week.
Thank you.
Thank you. You too. Thank you so much.
Bye, everyone.
Bye.